Yes, right now. Oh, Well, good evening, everybody. Good evening. Good evening. Good evening and welcome. For those who have not had an opportunity to meet, I am Sam Moskowitz, and I'm the president here at MedStar Franklin Square and a senior vice president with MedStar Health. And I'm delighted to see a number of people internal to MedStar Health tonight. I see some of our board members. I see members of our medical staff. I see members of our management team. I see our providers. So I thank them for coming. I also see a lot of people who are in the family but aren't here on our campus every day. And I want to also thank those of you who drove a distance. Traffic is always a hard time to fight, especially when you're coming from D.C. or regions around. So thank you for fighting. I can guarantee you this will be well worth your time tonight. So tonight is our 6th annual Alan and Gwendolyn Crouse Patient Safety Lecture. This year's lecture is entitled 20 Years After the Institute of Medicine Report to Err is Human. Where are we today regarding patient safety? And it's really an honor. It's an honor for me as the president of one of MedStar's hospitals to host this lecture. And I know MedStar Franklin Square is near and dear to the Kraus family. And in a second I'm going to call up Cathy, and I want to welcome members of the family who are here with us tonight. I feel almost as if I know almost every member of the family, and I do wish I would have met your parents, but I feel a little bit of a kinship to that. When MedStar Franklin Square and the MedStar Health Institute for Safety and Quality developed the vision that established the Alan and Gwendolyn Crouse Lecture, we imagined the sharing of knowledge both regionally and nationally, something that focuses on a critical topic within quality and safety and service to our patients and their families. And I must tell you, it's been an amazing 6 years of learning for me and for everybody that comes. And what gives us the privileges is we have some incredible minds that not only are within MedStar Health, but also we've brought some incredible minds to MedStar Franklin Square from outside of MedStar Health. I'm not quite honestly sure we would have been able to get some of the quality of the people that date back over the last 6 years, but I think a lot of it is a tribute to the vision that Dave Mayer and the team and the MedStar Institute for Quality and Safety started the journey for MedStar. So I thank those who are here tonight, our current speakers, who I'll introduce in a second, but I can tell you it makes me very proud. We see new faces every year. Tonight, there are as many people as there were here last year, But what's different this year is that we are live streaming tonight on both Facebook and YouTube. So I can guarantee you there are probably 3 times as many people who are tuning in to this lecture. And we're glad also to have you with us this evening as well. Thank you very much. Tonight we are pleased, and I know Dave Mayer is going to speak a little bit more, but we're pleased to have with us 3 people. Dr. Lucian Leap, who is the adjunct professor of health policy from the Harvard School of Public Health. Dr. Leap, it is my privilege to meet you. Thank you for coming. I also want to welcome Dr. Carolyn Clancy. Dr. Clancy is the Deputy Undersecretary for Discovery, Education, and Affiliate Networks for the Veterans Administration. And I have a special place in my heart. I was sharing with Dr. Clancy that I began my career in healthcare in the VA. And she had questions for me of names I couldn't remember. So before the end of tonight, Dr. Clancy, I'll give you some more names. But a special place in my heart. So thank you, too, for joining this evening. And then finally, Marty Hatley, who is the CEO of Project Patient Care and the co-director of the MedStar Institute for Quality and Safety. We've had the great opportunity to hear and learn from Marty in some of our past lectures. So Marty, thank you for joining us again this year. So I quickly mentioned Dr. Mayer's vision. And I do want to credit Dave for the vision that began our journey. And I don't take these words lightly, but I think it was Dave's vision that allowed MedStar to be today the recognized leader nationally and now internationally in patient quality and safety. So Dave, thank you. I don't need to stand up and tell everybody about the changes that we're seeing almost daily in our healthcare system in this country. We are now in MedStar Health starting another phase of our MedStar strategic plan. MedStar 2025 is just starting to kick off, and I would dare say that this next phase of our strategic plan at the system level will be very different. We have to recognize the changing forces in healthcare. So we will see changes. The strategic plan is not going to be the usual and customary. There will be one area, however, that will not change. And that's the unwavering commitment that we as a system have made to be the national leader in quality and safety in this country. And I thank everybody for being part of that. So every year I have the great honor of calling Cathy Mayer up to join me. Cathy, along with Dr. Mayer, made the Alan and Gwendolyn Crouse lecture a reality with a generous philanthropic investment. And we're pleased to have Cathy and David with us tonight, along with the members of the Crouse family. I want them to know that we're honored and we're proud to be a part of this lecture. For us, it's the real deal here. So we thank you for allowing us to be part of it and having the confidence in us to carry your name. So with that, I want to ask Dr. Mayer, Cathy Mayer, to come up. I want to give them a warm welcome. And for Cathy, they gave me flowers about 5 years ago, and every year the flowers get bigger. So, Cathy, thank you. And I'll take the flowers, and I'll give you the podium.
Thank you. come for the flowers, you know. Every year. They're so beautiful. Thank you, Sam, for that lovely introduction, and thank you all for coming, to all of the MedStar family who are here tonight from all over, not just Franklin Square, but thank you for hosting us. About 6 years ago, or a little over 6 years ago, when my husband came to me and said, I'd like to have a lecture, host a patient safety quality lecture at one of the MedStar hospitals. I think we should do it at Franklin Square. I said, yeah, great. We both were talking about, I don't know how many of you know, but my husband hosts, my name is Cathy Kraus, by the way, and David is my husband, that he hosts patient safety summer camps, started out in Telluride 15 years ago, with medical students, residents, interns, nursing students. We've had pharmacists, pharmacy students, you name it. They all come. Everybody has an interest in quality and safety. And it's a powerful program. It goes for several weeks in Colorado, Napa. Been around the world now. He hosts them in Australia, in Candor. So and we wanted to bring this to other people, not just to those people who are at those camps. My husband always said you have to educate the young and regulate the old if we're going to make quality, if we're going to make patient safety first and foremost in everyone's minds. And I think that's true here. We have someone here tonight who really has been inspirational in that, Lucian Leap. I'm not going to introduce all of you. David is going to, but these three esteemed panelists who are here tonight have been so inspirational to my husband throughout his career. They're heroes in our world. They have devoted their lives to making healthcare safer, as has my husband. If you've been here for the last 6 years, you know that each of these lectures have been about, we've tried to bring something from one of those summer camps here. We've had patients, advocates, and patients who have been harmed, who've been on our panel. We've had lawyers, and so that you can see that this is such a huge scope, and I've got to shut up. I only have 3 minutes. So again, thank you all for coming, and my husband is going to introduce these three amazing people who are going to talk tonight. David, I can ask you to come up now. David is the recent Vice President for Quality and Safety for MedStar and the Executive Director for their MedStar Institute for Quality and Safety. And I'm so proud of him and the work that he does, and that he was the inspiration. He is the one who wanted to do this. And because he's always trying to think of ways to spread the message. Thank you all again for coming.
I always say that one of these years I got to go before my wife because she's a tough act to follow, but thank you, dear. First, welcome, and it's great to see so many familiar faces and to be back here this year. As Sam said, we're very fortunate to be streaming this tonight and getting this message out and the importance of our mission to many people who couldn't get to this room tonight. So I'm really excited about that. Before we get into just a little background on the Institute and then I bring the panelists up, I've got to just acknowledge Judith Nowak, who's here in our audience. Dr. Nowak, please stand up and stuff. The reason why Judith is so special is because she came to this lecture last year and was so touched by what we did that she promptly said, I want to do a similar lecture in Washington, D.C., and I want to give generously to the MedStar Institute of Quality and Safety and the MedStar Washington Hospital Center. And we started a lecture this past spring, the Ezra Benethan Annual Patient Safety Lecture in memory of her late husband. So thank you very much. And thanks to Sam and the Franklin Square family, but in particular to Aaron Piccirilli and Deb Schindler, who have been great in pulling this together and stuff. You've heard a little mention about the MedStar Institute of Quality and Safety, and I just want to kind of take you through for 2-3 minutes and highlight some of the great work these teams are doing under the leadership of Katie Carlin, Marty Hatley, and others within our organization. First, on the research side, we had a very good month. Under Chris Goschel and Kelly Smith's leadership, we nailed 2 very large and very prestigious awards. One of them, under an Action 3 contract, went for $9 million, just under $9 million, to study diagnostic errors under Chris's great leadership and stuff. That was a huge contract that we got over 5 years. The second was another grant related to diagnostics, but setting up a patient safety lab in women's cardiovascular health and diagnostics. That's a combination of over $11 million. And I will point out that this past year, MedStar Health generated more money from federally funded grants through the Action 3 network than any other academic system or research entity in the country. So kudos to that group. On the education side, Cathy talked a little bit about our Academy for Emerging Leaders in Patient Safety and the Telluride project. That started really with an AHRQ small meeting grant when Carolyn Clancy was leading the AHRQ. We brought 20 students together at that time, and they seeded that program. Well, 10 years later, this past year, we brought over 250 students from around the world to these camps, including in the past 7 years, over 120 MedStar nurses, resident physicians, and Georgetown students, many of them that came from Franklin Square. So the program has just expanded. Carolyn, we've got over 1,200 alumni who have gone through our program, and it gets into educate the young. So we're very proud of that. Tim McDonald's here, the Center for Open and Honest Communication and the Candor work that was developed in MedStar's leadership is one of the key health systems to create the Candor Toolkit, another program that was started under the vision of Carolyn Clancy. Tim's now and the team are close to 300, a little over 300 hospitals now that are in some way implementing Candor. Either they've implemented it or they're just starting that journey. Tracy Granzik's here, the Center for Healthcare Narratives. People are going, well, healthcare narratives, what's the... Let me tell you, it is huge. Her journal, online journal called Please See Me, in the first week, the second edition came out, over 2,500 hits. These are physicians, nurses, patients submitting stories, poems, artwork around the power of narratives going forth. It's just amazing. And then finally, Mike Hoffman, leading our International Training Center for Bloodless Medicine. This program has really taken off across the world. Mike and the team knocked it out of the park at the annual patient blood management meeting. MedStar truly is a center of excellence when it comes to bloodless medicine moving forward. So just some of the work that's been going on within the Institute that we're very proud of. Now, I am so excited, as you've heard, about these panelists. When we thought of the topic and we said who would be the top 3 people we'd want to invite, the 3 people we wanted to invite are sitting right there, and when I reached out to them, all 3 of them said they would come and join us tonight for this session. So I am so pleased. I'd like to invite them to the stage and to join us as we start getting into conversations and discussions around this important topic. Yep. Okay. As they come up, I just wanted to add some more comments to their titles that Sam mentioned. Lucian has been a great friend and mentor through the years. I owe a lot of my thoughts in my career to him. He is generally the father of patient safety and has been, like I said, a mentor to many of us, and it's been so important. You heard Carolyn Clancy and all the work, I acknowledge that we've been involved in, but she clearly set the vision and the strategy for research around quality and safety over the last 15, 20 years and continues that work at the VA. And then Marty Hatley, many of you have met and know Marty from a personal standpoint, but you probably don't know the passion of this gentleman. Marty used to work for the AMA as a lawyer, and he got to meet, ooh, there was some hissing there, Marty. No, it's good. But to his credit, he met with a group of patient and family members who had been harmed from preventable but unintentional care. You know, it was intentional care, but unintentional harm. And Marty said, you know what? I'm leaving my job at the AMA, and I'm going to work with patients and family members. He did that almost 25 years ago, and he has continued that work as one of the leading, if not the leading, patient and family advocates, bringing that voice to the table. So I am so honored to have all three of them here tonight. Okay. So what we're going to do is we're going to start off with some questions that we want to set the stage for, and then after about 30 minutes, we're going to open it up to the audience. We want your participation. We want your comments and thoughts about questions either we talked about or something that you'd like to address with this esteemed panel. And I'll start with Marty. Marty, you were literally there at the beginning. You know, Lucian's paper came out. 1994, a few other things happened, but then you and two others decided we needed to bring a meeting together, and you set up really the first big meeting around safety and quality at the Annenberg Center. Could you tell a little history about that? And that really set the stage for the IOM report.
Right. Okay, so our colleague Tim McDowell, when he talks about Candor, he talks about special doctors and how we have to treat special doctors specially. I was a special lawyer. I was not only a lawyer, but I was government affairs for the AMA. And I was in charge of tort reform strategy nationally. We were trying to actually make it harder for patients and families to sue. And I was at it for years. So when you're a lobbyist, your mantra is put yourself in a position to get lucky. You educate, you inform, you strategize, you build coalitions, you use your PAC dollars, and we had a big PAC to make friends. And we thought we had hit the Holy Grail opportunity in 94, 95. It was the Newt Gingrich contract with America Congress, and they only had one healthcare agenda in that item, and it was federal tort reform. The fly in our ointment was Lucian Leap in his paper. Because he had basically broken the code of silence that said, you know, this is an issue we're going to talk about, is error in medicine. We're going to talk about it, we're going to name it, we're going to put it out there. And he did it in a paper published in JAMA, but I'll tell you, our editor, George Lundberg, had a lot of independence, and the rest of the organization was not aligned behind that. So we fought it. I did things that are very normal for lobbyists to do, including paying people who were on your research team to tell me about the flaws in the research. So it was, you know, it's war. The other two things that were happening that were really relevant is that the trial lawyers, who were our opponents, were flushing out stories that shocked the conscience of Americans, stories of error. And one of them was Betsy Lehman, who was a Boston Globe journalist who got an overdose of chemotherapy that killed her at a very prominent hospital in Boston. It's Dana-Farber. They've been very public about it. And the other one was the wrong foot case being caught up in Florida. How many of you have a vestigial memory of hearing about that case? Willie King, he was a homeless man. Both of his legs were really gangrenous, but he knew which one was the one to come off. It was the one that was the most painful. And what was really sad about that case that didn't really come out is that the surgeon who took it off, I mean, there were inconsistent entries in the medical record about which one should come off. So the surgeon got completely vilified and lost his career and his marriage over that case because it became so public. But those were the stories out there that defeated tort reform. Bob Dole was in the role of Mitch McConnell, now as president of the Senate. We passed tort reform, federal sweeping tort reform. Raising money, tens of millions of dollars, was easy for me, probably hundreds of millions of dollars when I think about it. because we were just going for this. And it was those stories and Lucian's data that actually knocked it out. So there was a moment of kind of clarity at the AMA leadership, like, oh my God, how could we lose this? We don't have the public on our side. We need to have a conference and draw attention to this issue. And honestly, we went into that conference thinking it was a public relations effort. We were going to assure the American public that the healthcare system was safe. I took it on behalf of the team to try to reach out to Lucian and ask him if he would speak. And I'm sure you thought I was just a horrible person at that time, no, Lucian. I hope I've regained some trust. I'm working on my karma. But Lucian had conditions, and he said, I'll come to your conference, but you have to invite someone that you really need, and that's James Reason. He was a cognitive psychologist and the author of a book on human error, the book on human error. He's British. You have to buy him a first-class ticket. You've got to give him a plenary spot, and if you do that, I will cooperate in your conference. So the conference happened. Jim Reason was a very, very powerful motivator at that conference, as was Lucian, who was a speaker. Lucian actually became part of the planning team. But we also did at that conference a case study on disclosure and open and honest communication after error. And it was from a hospital, it's Martin Memorial Hospital in Stuart, Florida, who made a promise to a family that an error they had discovered, it was an overdose of anesthesia in the OR, they would tell the world about it because it probably happened in a lot of other hospitals. That was the commitment they made to the family, and we found that case and displayed it. And the next day, after that case, we had front page coverage in USA Today. And on the third day of the conference, the AMA announced the National Patient Safety Foundation starting. The Joint Commission announced the Sentinel Event reporting system starting. 6 months later, we had a cover story on the Sunday New York Times Magazine about this conference. And then the IOM report invited us to present to them, and it really kind of, I think, changed the needle there from overuse, underuse, misuse to really a focus on safety. I probably took longer than you want me to.
No, but
I don't get to tell that history very often.
No, yeah, people don't understand that and stuff. But Carolyn, the Institute of Medicine report came out. You were at AHRQ, and then you assumed the leadership role there. You clearly, your vision, your leadership really changed in so many ways the agenda for research, for policy that came from research. Could you share how that Institute of Medicine report really, impacted you as you took that leadership role?
Yeah, so what I have to say is that some of my senior colleagues went to an Annenberg conference or two and came back transformed. You've seen people go to conferences like this, and they come home and you can't talk to them. They're walking a few feet above the ground. And so you pay attention to what's going on. When the report came out, we were enthralled, and it was pretty clear that we were going to be the lead agency for patient safety research. But it was also really clear that there was a lot that needed to be done right now, yesterday, last year, and so forth. So trying to bring all of that together was overwhelming and exciting and incredibly moving, particularly to hear people's stories. And it was through that work that we got to meet Sue Sheridan, ultimately that we got to meet Marty and many, many other patients who at that moment in time were brave enough to step forward and say to people, and frankly to a system that was fairly intimidating, this is wrong. This is not what we came in here for, and so forth. So we had a couple of things going all at once all the time. One is, how do we build a research agenda? And a lot of that was focused on building the foundations. Jim Reason gave the world an amazing framework, but we figured there was more to understanding why does this happen. Secondly, we realized we needed to build a field, so we funded some centers of excellence and a lot of career development and training grants, exploring areas where we didn't have very good information. And then we also funded a lot of research, which we thought of as cutting edge. And at the same time, our then director, John Eisenberg, was charged with getting all of the federal agencies together, and in 60 days from the Rose Garden, we had to come up with a report. So this is all of HHS. Understand that we fight all the time, right? I was in HHS then, it was VA, it was Defense and other agencies, but this was galvanizing. And we threw out ideas that right now feel like kind of normal, right? Like, do you pay for the surgery if in fact we did the wrong one or operated on the wrong patient, right? And that was just like, whoa, whoa, that might be a little too out there. I'm not kidding. But, you know, those were the heady days. And we also had a lot of external hearings for people to testify, and the response was unbelievable. I was very happy I didn't have to actually work the phones at that moment in time, because those poor people just couldn't get up, not for bio breaks, nothing. I mean, it was pretty intense, and so intense that we had to have separate sort of hearings for health professionals because they had a lot to say, and believe me, they had 3 minutes and they had to make it good. So one of the famous quotes, which I'm sure many of you will appreciate now, someone got up and made his statement very simple. Now, understand this is around 2000, right? To err is human, but to really screw up, you got to have a computer. For those of you who have suffered with electronic health record implementation, or many of them, I think you'll know what this individual meant. But a very, very exciting time, and people servicing issues that we hadn't thought about. But the most moving always was empowering that patient voice, because, you know, even after the AMA founded National Patient Safety Foundation, there was still more than a bit of defensiveness, right? You hear from a patient and it's like, we can do this. We can do it now, and we are going to do it. And it is very, very empowering. And enabling those same patients to empower others to step forward was also hugely important. So I'll stop there.
Solution, you started this all. It goes back to... You know, you were literally one of the first, if not the first out there trying to raise awareness. Your paper in 1994 in the Journal of the American Medical Association all of a sudden put it into the public domain for at least, you know, healthcare to read and to understand. But then the Institute of Medicine report comes out, and there were a lot of people who didn't believe the numbers that came from your research and others, and pushed back. Could you talk a little bit about that pushback on the Institute of Medicine report when it first hit?
Sure. Let me first, however, say that I met Marty Hatley for the first time when he invited me to join the planning group for the Annenberg Conference, and we've been close friends ever since. I didn't know him at all before that, and I did not find out till literally 6 months ago that he was carrying me down in print. But our friendship is still secure. And Carolyn's work, John Eisenberg's work, those early days with ARC were absolutely fantastic and absolutely essential. It was when the establishment took this and said, we're going to do something. So the movement's here because of action taken by the people you see to my right. It was very interesting because we published our results from a big study in New York State, which got the first data that showed how serious the problem was of medical injury caused by treatment, and how many of those were related to errors and therefore preventable. We published it in 1991. And, you know, there was a little article in the paper, and it just sort of disappeared. 9 years later, the Institute of Medicine came out with its report using that data from our study from 9 years ago, and suddenly the public became aware of it, and more importantly, the profession became aware of it, because they didn't pay any attention the first time because nobody else was paying attention. But when the IOM made it a public cause célèbre, then suddenly everybody in the medical establishment woke up, and we were then deluged in the ensuing, I think it was about 2 years, with a series of papers and analyses, all purporting to show how we were really wrong. The Institute of Medicine used the numbers from 91, and the attacks were all on those numbers. And since I was involved in generating those numbers, I had the opportunity to discuss this with various people. And it was fascinating to me because the threat was so strong that people who were really excellent researchers did things that were really quite strange. one person who I will not name because I'm not into blaming or anything, but as an illustration, who was a very highly respected researcher, reanalyzed our data using a different approach to it. And he made and came out with a conclusion that wasn't nearly as bad as we said. He made a very incredible methodologic error because the medical practice study was based on looking at records to see if patients had certain things that suggested they might have had something go wrong. Did they have a fever? Did they go back to the operating room, et cetera? So that we looked at them as clues, and then we went in to find out if indeed there was an adverse event. This person took those instead of as clues, he took them as predictors, and then using them as predictors said that we had come to the wrong conclusion. Well, that was a total misunderstanding of the paper by somebody who was very smart, which to me said, this is really pretty deep. We're really getting to people in a big way. So there were a lot of articles written by very good people. And as I was saying to Marty and Carolyn before, I decided the only way to handle this was to ignore it. Why give them additional press time? I wish the Democrats would learn that about who. But it worked. I mean, after a couple of years, they quit writing those things. And then a few people started looking in their own hospitals. And you know what they found? It was worse than we said. And of course, we knew that because it was not a great study. I mean, it was looking at medical records. Well, any of you who have looked at medical records knows what's not in them. And so we were clearly missing a lot of things. We were not seeing things that weren't there. I mean, we weren't making it up. So I knew from the beginning it was a lot worse than what we said. So they could say all they want, but when the dust settled and when people really started getting serious about it, they would find we had a serious problem, and we did.
Great. So next month in November will be 20 years, and I'll go to Carolyn first for this one. What's worked? What have we done well, you think, over the 20 years in progressing to a safer healthcare system?
So a few things I can point to that say what's worked. I think first and foremost, I would say, is having more of a voice for patients and families. I spoke at a Maryland Hospital Association conference, I don't know, about 5 years ago, and I was quite amazed by how many hospitals had patient and family advisory boards and had given some very serious thought to how to respond when a family member steps forward and who, God forbid, has lost a loved one to what they believe was a medical error, and that they probably weren't ready to think about the broader issues right at that moment, but they had a path and a journey for them to go through and so forth. And I just think making that real is hugely important. There's a lot of public reporting that goes on now, particularly about infection rates. This is something everyone understands. And I think we've made big improvements there, probably not enough. And we also talk about these things. I mean, Lucian, I'm going to guess when you published your first papers, you wouldn't have bet that, I don't know, a dozen years later, a surgeon from Mass General, this is Mecca for my family, I'm from Boston, right? Relays and tells the painful story about how he did the wrong surgery on a patient. The charts got confused. It's mid to late Friday afternoon, where everyone just wants to hit the road and so forth, and how horrendously he felt about it. And a lot of this was reinforced by a language issue or not helped by a language issue with the patient and so forth. And before Annenberg and before Lucian's research, no one ever talked about this out loud. It happened, but it was rare and unusual, or that was the perception. And I would guess the last thing that worked, I would say, was the big central line study. Chris Getchell was clearly the co-pilot on that, who's now with MedStar. Really, really quite amazing because it changed people's ideas about what was possible. The idea that people got infections from central lines, yeah, we know that. We keep trying hard. We're as sterile as we can be, and that's about it, but they keep happening, and these are sick patients. Until Peter and Chris got teams to work together and actually watch the rates go down. And if you've ever talked to a team that's gone through this, it's unbelievable. Because on the other side of this, that success is like rocket fuel. And they have to be pulled off the ceiling because now they're taking on world hunger and peace and everything else. But because it's that empowering.
Thanks. Marty, what would you add to what's worked?
I think in the last 20 years, we've really defined harm in healthcare, preventable harm in healthcare, as a public health issue. So that was intentional. I think that's the right place for it. I totally agree with Carolyn about that we have more data and better research. And that's not just shaped work here, it's shaped work internationally. I mean, HRQ is the biggest funder of this kind of research in the world, and every country is paying attention to this. I think we shined a light on the cultural obstacles to the kind of transformation we want to see. And part of that is the culture of medicine, the deny and defend stuff that we're working so hard through Tim's Center and on Candor, which, again, that is, in itself could be a major accomplishment that we would cite. But also the continuity of care issues. I mean, the sense that, the patient journey knitting together, I think that's a huge, huge issue that we haven't resolved yet. And then I do think the whole issue of patient as partner. I mean, patients were socialized for many, many generations to be passive, to just go in and follow their doctor's advice and not speak up and not be a full partner. And I think we've changed the needle on that.
Great. Lucian, one or two other things you would add to what's worked?
I've now been retired for about 5 years, and I used to pride myself on never using notes for a talk and so forth. But my memory's not as sharp, and so I have a few notes, and if you don't mind if I look at them. I really echo what's been said, but I think that what we did was we changed the conversation. We made it. We started talking about the whole thing in a very different way, and that was the point, and that is that it's not bad people, it's bad systems, and that this was the big insight from the human factors and cognitive psychology people. But people really began to buy into that because this was a shining light in a very dark room. That there was a way to do something about it, and that's why there were hundreds of people coming in dark and so forth. And so we began to think about and talk about the whole problem of unintentional harm in a very different way. And that made people really begin to think seriously, what do you mean by systems and how do you change them? We're still trying to figure that out. It's still not easy. It's not easy to change your ways, but I think there's not much question that everybody now speaks the same language and we know that that's what we're talking about. I think we've made a lot of practical improvements. Carolyn referred to Peter Pronovost's work with central line associated bloodstream infections. That has taken off nationally and internationally, and there are thousands and thousands more people who are living today because of that. We've had other big hits. We've certainly reduced hospital infections overall a great deal. We've certainly reduced medication errors a great deal. And we've certainly, I think now, nobody goes into the hospital without somebody asking you every 5 minutes, what's your name and what's your date of birth? Okay, but that's the way you keep from taking the wrong leg off, or et cetera. And so we have really gotten that established. I think that probably 95% of people in 95% of hospitals do disinfect their hands now before they touch patients. We've made some real progress. So we've had some really impressive gains, but all of them seem a lot less than the big change, which was to get everybody to sort of think in larger terms, in terms of the culture. And I want to come back to that later. I think we have made some real progress in medical education. Certainly the work that's been done by David and his group, the Telluride group, where we have now literally over 1,000 people who have learned about patient safety that way, and in a meaningful way. The experience is so intense that it's with them for life, and it makes them real dedicated workers. But also the IHI Open School, which has filled in a lot for the fact that the medical schools have been very slow to come around to teach about patient science. And the students want to know it more than the faculty want to teach it. And so they go, not just to Telluride, but they go to the IHI, open school, and that sort of thing. Medical schools are slowly coming around, but still, I think, too slowly. I certainly think we made a lot of progress in the whole area of candor, in being honest with our patients, disclosing, apologizing, and then trying to make amends and make changes. Again, a work in progress, but I'm very encouraged with the information you've given us, and I think the work we're doing back in Massachusetts in this. We really haven't gotten the widespread acceptance of something that seems so obvious, which is that it's better to tell patients the truth, both for them and for you. But we're coming. And then I guess I would like to say that I think that we've had some impact from the work of the Lucian Leap Institute, which was set up by the National Patient Safety Foundation to get the biggest minds in patient safety to think about major issues. We identified what we thought were 5 transforming concepts, that is ideas, concept that it was essential to deal with if we were going to move ahead in safety. And we have then, since then, had roundtables of experts and generated white papers with those summaries and conclusions, which I think have had some impact. It's hard for me to know how much impact, but certainly there are things that people talk about, and they're part of the shall we say, the deeper dive of changing the conversation. So I think we've made real progress. We're all frustrated by the fact that it hasn't been nearly enough, but we should look on the sunny side to begin with.
That's great. And, you know, again, for those that are watching and streaming, I'm getting some great questions here that are sent in. Lucian, I'll start this one with you. What is the one thing that has been the most difficult thing to change over the last 20 years?
The culture.
Culture.
It's obvious that although we can do great things, like getting people to wash their hands or to reduce central line infections, these are just on the surface. The more fundamental thing is having a culture where everyone who works in an institution, from the CEO to the people who clean the floors, everyone feels that safety is their personal responsibility, that they see their job every day as keeping patients safe. They look for hazards. They look for ways to improve. They feel safe in doing that. They have an environment that supports them when they do that. They don't get blamed. They get to be part of the solution, where safety is part of everybody's work and is fully supported. Now, this, of course, is what the human factors in cognitive psychology people wanted to see happen. That's why they were so excited when we first started. The first Annenberg, a third of the people there were outside of medicine. They were people who had been working on safety, and they were so pleased to see that healthcare was going to do it. And they got very involved and very excited. And then as time went on, they began to realize that very few people were listening to them. They were at MedStar, but you're the exception. There aren't very many places still in which they are part of the essential action. And so they sort of faded in the background because, of course, it's a power thing. It's a power thing. The establishment viewed what we were doing as a real threat to their status quo, as indeed it was. I mean, what we were talking about was truly revolutionary. And not surprisingly, they balked. CEOs of hospitals, leaders of professional organization, they have paid lip service to patient safety, but they have not been, for very understandable reasons, wanting to make the change. And of course, they don't have the courage to confront their doctors who also don't want to change. It is very simple that when you think about what happens to, a good example of this is the whole business of work hours. Work hours was a situation for which the evidence is clear, the science is clear, common sense is clear. We all know if you've been up all night, you're going to make more mistakes. I mean, big deal. And so the big push was put to regulate residence hours and to make them more humane and so forth, with a fair amount of success, and then the profession fought back. And they backed down, they backed away from it. And so this is what happens in movements, and this is what's happened to us. So it's a power thing, and the power establishment isn't giving up. It's also a gender thing. I know that's an interesting word nowadays. Sound familiar? Power, gender. I happen to be one of those people who think there are real differences between men and women, and that one of the most important differences, and it's a generalization, many exceptions, like all generalizations, but one of the important differences, women really are more interested in relationships, and they're better at it, and they work at it more than men do. And patient safety is about relationships. Big surprise that the first people in, the most enthusiastic people, the people who've done the work, are nurses. 95% women, at least at the beginning. Right. Indeed, absolutely. Absolutely. So it's nurses who immediately grabbed it, nurses who've done the work, nurses who are the major people doing the work now. Is it women's work? 86% of the people who've been certified in patient safety are women. You go to any conference, I think maybe even tonight, the majority, safety conference, the majority are women. But the men are still in power and are still blocking it. And that's the challenge we have. There are major exceptions, of course. John Eisenberg at ARC, of course, was one of our great leaders. Heads of major systems, Bob Waller at Mayo Clinic, David Lawrence at Kaiser Permanente, Gordy Springer at Alina. I'm looking so I don't leave out names. And currently, Gary Kaplan, Virginia Mason Medical Center. These are men who have got it and who have done what needs to be done and taken leadership. But sadly, they're not a very big number. And we still have the vast majority who still aren't on the game. So bottom line, I think we can say we've had thousands of small process and systems changes that have made a difference. But we haven't had the big system change, the culture change, in which we will really will enable us to deal with the big problems, which are hours and workloads, an environment that supports people and enables them to be active participants. So the culture change is still our challenge.
Carolyn, one aspect you think the most challenging, is it the same or something different?
Well, I would reinforce Lucian's point about relationships. And just to give you a concrete example, do we have people working in anesthesia here? Groundbreaking initial work, right? But what was it all about? The machines, not about how does anesthesia work with surgery, work with nursing to actually, and safety is a team sport. So you would think that many men very interested in sports and teams might actually click on that. But not yet.
They all want to be the quarterback.
So two areas I'm worried about. One is I don't think we anticipated how rapidly healthcare would be changing. So many procedures that used to be done in the hospital, and then we know where you are, right? You don't go anywhere unless we say this patient can go get a test or whatever, are now being done outpatient, which is great for patients, right? Who needs to be woken up all night for a variety of reasons? On the other hand, I worry that people get home and can't find the memo because we haven't written the memo telling them what to do if they have problems and so forth. And when I look at some of my extended family, I believe a couple of extended family members have died from Coumadin. That's not on their death certificate, but between multiple medications and getting doses wrong, my father had some big misadventures with that. Straightforward things, to say nothing of people who are seeing multiple clinicians and so forth. So I think that is probably the biggest issue that I worry about. The other thing is I think that in our interest in transparency, in some instances we've sort of weaponized measurement. Yes, infection rates by a care facility, got it. We need much, much more about what's happening in ambulatory surgery and other ambulatory facilities. But, some of the complications ones are very, very tricky, very useful tools internally, probably not as helpful for public reporting. So I'll leave it at that.
Sure. Marty, anything quickly you wanted to add to that?
Yes. I want to pigpile on Lucian and mention two other leaders that I think have had huge influence, and one of them is President Obama, because the Affordable Care Act made patient safety a priority. That was the tort reform policy of the Obama administration, and I think that needs to be called out. I am a Democrat, by the way. And the other one was Don Berwick, who really made a huge contribution to the field in many ways, but especially with the Crossing the Quality Chasm report that he produced and worked hand in hand with Obama. I think quickly, David, the issue I'd like to highlight is just we haven't done this, is maintaining a sense of urgency about the third largest preventable killer of people in this country. I mean, it's there in the literature, but there's just not enough people raising their voices saying this has to stop. We should be, as a community, outraged at the amount of loss of life that we have here. So I think that's what we've got to change.
Okay, I want to open it up to the audience, and we'll alternate some questions from the audience and the ones I'm getting from people who are watching from their computers. So who would like to volunteer to? There's a gentleman down there. Thanks, Aaron.
The effort was initially put forward by Leapfrog, which was industry-driven. How has industry changes made this effort less effective? Payment, government. That's my question.
I can speak to that. I'm on the Leapfrog Group Board of Directors, and I'll tell you, they have kind of a similar conversation. They were less successful at getting large employers who have access to, patient education materials through their HR programs to be engaged. And there are people from Leapfrog here, they would be saying the same thing about where is the sense of urgency around this issue. I think they've been successful in their first three leaps, their original big leaps, which was looking at volumes, requiring disclosure. I'm blanking on the last one, but electronic medical record. So they've had an impact in the field and shaping it, but they would say their mission is far from done. And of course, they've got the grading system now, which has really taken off and is being used by Americans, but Dave and I have a continuing conversation, honestly, about whether that grading system actually, kind of to your point of weaponizing, whether grading is measuring the right things. But that's a continuous improving part of Leapfrog as well. I mean, we're constantly looking there at how to make that grade better.
Yeah, the only comment I would add on payment is we don't have an easy way, and with flawless electronic records, which we haven't quite achieved yet, we may get there. But, the attribution problem ends up wasting a lot of money. So in order to, penalize what are thought to be avoidable mistakes, we have to invest a huge amount of time and resources in having present on admission codes. This does, of course, lead to bad jokes about the epidemic of pressure ulcers in ambulances and things like that. But apart from that, it just uses a ton of time rather than focusing on what's wrong with this picture and how do we do better. That's really what I meant by weaponizing.
And this is Jill Berger from Leapfrog. Before I worked at Leapfrog, I was 20 years at Marriott running benefits. And before that, I worked at GM when this whole initiative, the Institute of Medicine report came out and Leapfrog was founded. So I feel like it is one of my babies. But so I was brought on to Leapfrog to put together an employer, we're calling it the National Panel of Employer Benefit Innovators. So we've got right now 13 very large national employers that we are going to bring together next month to say, how do we innovate? how do we keep this going? So we're very excited about that.
Jill, if I could just respond quickly to Jill, one of the things that excites me about Leapfrog too is you've got some really hard-hitting employers there too. And this is off topic, but I was never prouder to sit next to somebody from Walmart than when they stopped selling guns. And so we have the opportunity there, I think, with someone in our sales to really get them to be looking into other causes of preventable harm in this country. Thank you.
Here's one that's coming from Facebook, and it's from one of our good friends, and really it does great work. Colonel Stephen Coffey. Stephen, thanks for joining us tonight. Stephen's question is, how could we get the culture in the C-suite that is resistant or doesn't want to buy in to change? Go ahead, Lucian.
You want me to say what I think?
Yes, I do. I've never known you to be shy.
Well, you can use a carrot or a stick. There's a carrot looming, which we're hopeful about, and that is to change the payment system. The fee-for-service system gives all the wrong incentives in addition to stimulating an excessive amount of care, which in itself is harmful. It also pays people for hurting us. You get paid more when the patients are in the hospital longer, even when they say they don't do that, they still do. And so the average CEO isn't too motivated to do something that's going to bring in less income. There is a movement, and many of us think maybe this time it'll work, to go to capitated payment and the accountable care organization model. And if indeed that happens, the incentives will be reversed, and I think we'll see some very positive influences on safety because suddenly it'll be helping the bottom line rather than, as they perceive it, hurting it. But that's not going to do the job by itself. I think we need the stick. And we were chatting about this a little bit earlier. I think the single thing that's been wrong with patient safety is there haven't been consequences for hurting people. We do not have accountability, and we have to have accountability. We make a mistake, the patient pays. That's not right. It pays in every sense, not just dollars, of course. So if you believe it's caused by faulty systems, which I do, then the obvious question is, who's responsible for the system? And the answer is the healthcare organization. And so it's the healthcare organization that needs to be held accountable. And I suggest there are two ways we can do that. The first is something many of you have probably never heard of called enterprise liability. And this, in simple terms, this means you sue the hospital instead of the doctor. This doesn't happen because most states have laws in them that limit the liability of eleemosynary, that's a long word for saying not for profit, but they really are, organizations. And so in Massachusetts, you can't hit up a hospital for more than $30,000. A lawyer won't take your case for $30,000. So that has to change. And so if we had enterprise liability where you could sue the hospital instead of the doctors, you can bet your bottom dollar that the CEOs will get a lot more interested. But I think we need something more than that, and that's regulation. As we said, educate the young and regulate the old. We're long past needing to do that. We need a federal patient safety agency, patterned after the FAA, to do three things: to set standards. National Quality Forum will be happy to develop them for them. They have developed them, but they need more. Set standards. Number two, monitor compliance, require compliance, monitor compliance, not by just self-reports and so forth, but by real reports, by audits, by site visits, by really saying we're serious about this. And then finally, of course, sanctions. Penalties when you don't do the right thing. They can be warnings, they can be fines, they can be loss of accreditation. But we need somebody to say, here's what you have to do, set the standards, we're going to make sure you do it, and if you don't, there are consequences. For the doctors, the Federal Patient Safety Agency has to say to the organizations, it's your job to make sure your doctors are doing a good job by by having meaningful performance evaluations and by having meaningful assistance for them to improve, but insisting that they meet the standards. And that's also part of the setting the standards and enforcing them. So I think until we do that, we're really not serious about patient safety.
And before I ask Carolyn and Marty to comment on that question.
Oh, excuse me.
Yes.
I forgot the most important line.
Yes.
Is it doable? Yes. Is it likely? No. But maybe we should get a children's movement going.
There you go. Lucian has to get back to Boston tonight for a commitment and everything, so I promised him we would get him out by 7:30. We're going to continue the panel with Carolyn and Marty, but Lucian, I want to make sure you get in your ride and back to the airport on time. So thank you so much for being here tonight.
Thank you all for coming and for always great.
I look forward to talking.
Yeah, I'll give you a call. Thanks, bro.
Mr. Marty.
Yeah. My old enemy. Oh, my heavens.
A little gift for you. We don't want you to take it back in the plane. We will ship it for you, but it's a MedStar Health Institute for Quality and Safety physician's jacket with your name on it. So
white coat.
Honorary member of our faculty.
I'm honored. Thank you. Thank you so much.
Thank you for everything.
Thanks for it.
God, what a great gentleman. Carolyn.
So the question was, what more can we do?
In the C-suite, you know,
Oh, in the
change
C-suite,
that
yeah.
C-suite mindset.
Sorry. Well, no, Lucian elaborated with such detail. I forgot the starting point briefly. I think actually energizing boards would help a lot. I can't see where Sam went, but you know, if his board said to him, this is important to us, what are you doing? Where's your list? How come I walk through your halls and I don't see this? And by the way, do you welcome ideas from your frontline staff? Many of whom have great ideas. Now, some of them may not understand complex systems, but they're there on the ground. And we know from a little bit of work, that, I mean, this is not Nobel Prize research, but nonetheless, that those boards that have a dedicated quality and safety subcommittee tend to actually be more focused because they drive the agenda and they start off asking very basic questions like, okay, hand washing rates, how do you know? It's a really good question, right? How often should you be checking? And so on and so forth. Because usually boards have pretty smart people. That doesn't mean they know the technical details of healthcare, and they might be a little nervous about it. And I will tell you that one of the most inspiring commentaries I read in the New England Journal in the past few years was a physician who runs a North Carolina system brought his board on rounds around the hospital, which I think is exactly what you need to do because they can see it. Does this feel weird to the board members? Oh, yeah. Big time. Oh my God, what are all those machines? Okay, I think we're done now. I mean, it's scary stuff, and I think that was actually at the heart of some of the work on the central line infections. But, you know, Peter and Chris helped them work through that, right? Because they convinced them that their presence was so important. I think we need much more of that.
Great. Marty?
You won't be surprised by this, but I think we need patience on boards of directors. I think we need a different composition of boards of directors. They should reflect users of care and the community. I go into too many boards of directors that are honestly just too white. And it's, you know, it's 2019. We need to be changing that. One thing I want to call out, Carolyn, because you kind of prompted me for this, but what MedStar Franklin Square has done is they've connected their PFAC in their board of directors by having a board member sit on the PFAC, Colleen LaPresto. I don't know if she's here tonight, but they have a great success story here about a PFAC meeting where the PFAC members, and some of them are here, Bill, Pat, I see you, asked, why isn't our hand hygiene goal 100%? Why is it 80%? And that went to the board really fast because of Clean's connectivity to Sam and the others, and they made huge, huge progress. So there's lessons like that. So I think that's the major thing I would say, Dave, is just let's have our boards reflect our uses of care.
Great. A question out in the audience. There, Terry.
Terry Fairbanks, and I have Lucian. All three of you have had huge impacts. Lucian knows the ways. I finished medical school just as the report was coming out, so I had a research career. Carolyn funded my first grant, and then I used to get texts around saying, Carolyn Clancy has one of your slides on the ED pharmacist. And then that helped, I think. And then Dave, both of you have influenced me because I had never really brought patients in the way that I did once I came here. So that's the preface that has nothing to do with my question. But thank you. And so my question is, we've talked, I really love what you said, Carolyn, about the metrics and the weaponizing. On the other hand, I find, and we experienced that, but on the other hand, I find myself wishing that we had a good metric for safety. Because metrics have driven quality, and I think if you look at hospitals around the country, they've moved quality in the metrics that are measured and that matter to them very, very quickly. And we don't have the same kind of public drive for safety. And I'll just make the point related to your, I have found myself saying that now these public measures of quality have become the best reliable, highly correlated measure for how good a health system's data analytics team is. And it doesn't mean, you can't have great metrics if you're not also providing great care, but we need a metric for great care in terms of safety, and I think that's a dilemma. I'd love to hear what you both have to say about that.
So Marty reminded me of this earlier, and I didn't tell him one piece of this story. So I guess in 2012, about a year before I left ARC, we launched a project to actually figure out what it would take to have patient reporting, patient and family member reporting. And it's ironic because in many healthcare institutions these days, they'll give you a little clicker, or you can go to a kiosk, or they'll beam you on the iPhone. I don't know what service you get anymore that somebody's not sending you a little follow-up. And we should be asking about that. Now, the big question here was signal to noise, but there was a little bit of work that showed that could be fairly reasonable. For a variety of reasons, we didn't get the actual project off the ground. I lost track of it and actually tried to track it down a couple of years ago. I was told it had been taken over by one of the QIOs. I'll just tell you, making a cold call, I couldn't figure out, nor could they, who knew anything about this. But I think it is more than it's way past time to actually have that. Because if nothing else, even if we didn't find more safety issues that we could put a scientific label on, we would be far more responsive to patients' needs, which could never, ever be a bad thing. But we would also get clues about what we're missing. Because unless you walk around with people all the time, you just don't know that.
Terry, I find it interesting that we don't have the data to put together, or the processes to put together, safety metrics 20 years after the IOM report. And I think for me, as sort of somebody who is at an interface between the outside, I've never worked in a hospital, but that's still a sensitive topic. CDC still doesn't track deaths from preventable harm. Death certificates are wildly inaccurate. Probably the most frequent thing I hear from patient advocates is my loved one bled to death in the hospital, but that was not on the death certificate. What was on the death certificate is cancer. That is a very, very common narrative in the patient community. So I think we've got to deliver better data. Leapfrog Group runs into walls with hospitals, especially, who won't share their data with them. The more data we produce, the better the metrics can become. I sit on the NQF process to develop what hospitals are going to be measured by, and how much of that is tied to payment. And the lobbyists come in, and they are very well oiled to say that's not we didn't have a metric for pressure ulcers for the longest time that was NQF endorsed because they were always faulty. So it's kind of that enemy of the good is the perfect. I think that's kind of where we are in that dialogue. And I just really have to, I want to see that change so badly.
So I would agree with you in many ways. The one caveat is, if we believe that this is systems, and I clearly do, measuring the upstream processes is really hard. An infection, I mean, part of what gave patient safety its urgency is people can understand it, right? You haven't lived till you've testified before House members or senators who are saying, let me understand this. 4-year-olds forget to wash their hands. What is wrong with American doctors and that kind of thing? But the notion that you came into the hospital for one reason and got a second problem that might have been worse, or God help us, might have killed you. People actually understand that. Supply chain is a little bit harder to explain, and I'm not sure that we need to, but boy, in the same way that I know that airlines do their safety checks, I would like to know that they're doing that. And I think, as many of you have observed, anytime you see any trade press, right, what are they talking about? Supply chain, we have no idea what we're doing. I can't guarantee that we've got the right supplies here. It is still very commonplace in U.S. medicine that like 5 minutes before OR time, someone's running across the street or calling a friend to get their supplies. Ridiculous.
Terry, one more comment. When I met Jim Reason in October 1996, he basically said to me, Marty, we've been waiting for your phone call for 20 years, but you have the most complicated human activity in the face of the earth to manage. And so I think, and that complexity has only grown since then. So I think part of the devil here is just managing, all of the factors that go into what is a safe metric. There's nothing else like it. Nothing else like the work that you all do every day. Managing variation. I mean, a huge part of safety is standardizing, and you've got to standardize where you can, and then, constantly customize to the different patients and families that you have to treat.
So we've mentioned her name twice. Chris Goschel has just chimed in with a question. She said she wants to ask the panelists, what low-hanging fruit is still out there for healthcare leaders and policy analysts to go after that would be simple and very effective?
Well, I would actually like to know Chris's opinion on whether anyone has gotten medication reconciliation right. I mean, it sounds so simple, right? It's like cleaning up Legos or something, except it's very, very hard to do systematically. And let me just say how thrilled I am that under Chris's leadership and yours, that you're going to be focusing a lot on diagnostic errors. Having had the privilege of serving on that committee with Chris, I got to be on the subgroup that changed the definition. Now, understand that a big part of what IOM does is to put out clear definitions, and we got the part 2 in, which was not an easy sell, but a diagnostic error is when a clinician can't come up with an appropriate explanation and or has not communicated to the patient and family. That was a struggle, right? What about people who are mentally ill and stuff like that? No. That is part of the definition. So I think that is, and even within diagnostic errors, I think there's going to be easier things to pick up, like tests that get lost at hospital discharge and that kind of stuff, but also much, much richer layers to it.
Marty, anything you want to add about some low-hanging fruit out there still?
I mean, I think the one that just seems to me, I've already mentioned it, but why aren't we tracking errors as a cause of death the way we track other causes of death? I mean, there's a CDC mechanism for that. It just seems like that should have been done by now. And the other one, I think, is Candor. I mean, Candor is out there, it speaks to everybody. It speaks to providers. It speaks to organizations. It speaks to patients and families, and it's got momentum. So we're seeing states really embrace it, but so far we haven't got the country. So I think that's going to continue.
So I have to brag. This is standard policy at VA for over 10 years. We, of course, don't call it Candor. We call it directive number whatever. But I will also say it's hard. Some of my colleagues did some great studies with surgeons, highly qualitative, but boy, it insults and really assaults your sense of what am I here for, right? And I went in to help and things didn't go the way I expected, or we made an easy error or a very tough one, and now it's on me. And explaining that to the family is hard, but it is hugely, hugely important.
Okay, microphone, who's got it? Roger? Is there oh, she's got it, go ahead.
So, Marty, you mentioned the off-cited statistic about medical error being the third leading cause of death. And I have to say, the other day I received an email from Medscape, but an incredibly popular, especially among patients, website for medical information. No human error or no medical error is not the third leading cause of death. And I've seen a trend in these sorts of articles, and I'm wondering if that's a murmur that either of you have sort of encountered, and especially 20 years after the IOM report, if it's something we have to worry about and what our response is.
I mean, I expect it now. I mean, I've seen it so often, so many times. And part of it is when we use the word error, there's a lot of judgment built into that word connotatively. We hear that word and we go, oh, this is a judgment about me as a human being. So it kind of gets to the point that I think we've all been making about the importance of a systems approach. But I just expect it, Melanie, when I see it now. It's been around forever. And, this questioning about the extent of the problem. I mean, third largest cause of harm, I mean, a lot of that work is in statistics. We know very little about the harm that happens in ambulatory care. We're working on it through here. There are horrible reports out from the OIG, 2016, 2018, 2019, about long-term care, skilled nursing facilities, rehab centers, especially on weekends and evenings. I mean, those aren't really making it into the statistics yet. And then home health care. I mean, we are asking patients and families, there's 4 million people every year that are giving home health care treatments to a loved one that are complicated medication management, wound care, feeding tubes, that sort of stuff, things that I think of as nursing tasks. So I think the numbers are still low, and I've just made my peace with the fact that we're going to always have that murmur of questioning the numbers because they're uncomfortable.
Yeah, obviously there's lots of issues with definitions and so forth, but I always thought the most effective response to this was shortly after the initial Institute of Medicine report, when they talked about 44 to 98,000 deaths per year from avoidable harm. That got people's attention, and a former member of Congress who served on our advisory council encountered a doctor who just kind of went ballistic about this and said he didn't think it was more than 20,000. And this former elected official said, and that would be okay? I mean, that was the end of the conversation. Whatever the number is, it's too high. And there is more than a little bit of competition for like which condition, and are you a lump or a splitter in terms of how you define things. So I think of that as background noise and some defensiveness, but really we have too much that we haven't cured this.
Question that came in through somebody watching on Facebook, and we briefly touched on it, but it's for Marty and Carolyn. How do you balance accountability with compassion for those at the bedside or the team that was involved with medical harm?
This is why I love Candor. I think Candor is the best thing I've seen that does that. I think there's huge common ground there of the empathy that happens in Candor training between providers and patients is palpable. You can feel it in a room when Jack and Teresa are in a room. The wall drops, the conversation happens about everyone's trauma. And I think it's a huge portion of the problem, and it really needs to be addressed. I think we're changing the dialogue from second victim to understanding that, I don't like that terminology, but it is trauma for people in the healthcare workforce who are involved in an event like this, and that trauma is too often not addressed and needs to be thought of in the same way. There's a lot of patient advocates who are uncomfortable with the attention being put on the caregiver and not enough on the patient, but I think they belong together.
I agree with that. I mean, first of all, I'm a huge fan of Candor. We funded some of the initial work, and explaining it to people, because it was really so groundbreaking, was actually a little bit tricky. Tim, I'm sure you and Dave have had that experience. You're doing what? What I like about it is it actually shifts the focus a little bit from I feel bad to you think you feel bad. I mean, this patient and the people who love that person are struggling with why did this happen and so forth. But I agree with you, Marty. I don't think we give enough attention to that. In VA, this is very, very painful for me with respect to suicide prevention. You know, we've got a crisis line which works stunningly well. I mean, you know, in 8 seconds or less, you're on the phone with a human and so forth. And they can connect with people literally all over the country. It's quite amazing. And sometimes, despite our efforts, we have the dreaded outcome. And we don't build in time for people to kind of grieve together about this. And I learned this because I learned from some of our coordinators who have actually reached out to their counterparts answering the phones and actually set aside some time, but I'm sure you all know this was their time. We don't think of that as part of the job, and I think we need to change that.
Dave, if I can say this to Carolyn too, I mean, Candor isn't just about open and honest communication with patients and families. It's with each other. It's with all levels of the organization. And I don't think that was part of the CRP dialogue as much until the work that you did on Candor, where it just emerged as this huge need of the workforce. I mean, the things that make us want to hide, the fear, the bullying, all of that sort of stuff goes into what keeps us from, you know, learning from our events. And I also just want to thank you because it was those small conference grants that really helped get some of the consumer organizations off the ground too, including Consumers Advancing Patient Safety. That was a small conference grant. The first patient and family engagement workshop in this country was funded by you. So I just wanted to get that in before the camera stopped rolling. I'm very grateful for that work and for your leadership.
Yeah. Was it Roger? I think you were.
Carolyn, Dave stood up our patient family advisory councils in 2012, and he began with creating a system council of nationally recognized individuals, including Marty. One of those individuals is Rosemary Gibson, the author of The Wall of Silence, The Treatment Trap, and her most recent book was China RX. And this, if you're not familiar with that, this may be an unfair question. But in that book, she outlines how we have become dependent that the active pharmaceutical ingredients in so many of our drugs and almost all of our antibiotics come from China. And the impact of this potentially for the Veterans Administration or for our Department of Defense, if they were to cut off supply, or if their manufacturer, like the heparin catastrophe of several years ago, were to occur is frightening. When we talk about quality and safety here, I think we have a need to be able to address that. And I don't know if your insight from the government procedures, whether this is being recognized or is a concern. And it deals with big pharma's influence.
Well, it's clearly much more than a technical scientific problem. I think there are many who believe that we just don't know enough about what goes on in factories in a number of other countries who have become, in fact, major suppliers in this country. To the extent that we can, we are not purchasing that at VA, but for some things we definitely are. Now, we're lucky because if we have a problem, we're a big enough system that someone's going to pay attention, right? This is not happening at a urgent care clinic at the CVS down the street. I guess they're minute clinics, but whatever. You know, we've got a voice and can actually make noise, and we do. In fact, some days I think the FDA thinks of us as their best friends because we have the capability of monitoring for that all the time. But it's the what we can't see that is really, really scary. You know, where's the next one coming from and so forth. That scares me a lot.
I think we've got time for about 3 more questions. We'll go there first.
Martin Sheridan, just a question. The recent epidemic on opiates has made people more alert. My question is, with education in medical school and nursing school concerning medical errors, I mean, there are courses in public health universities, but not in medical schools, as well as the thought that instead of candor at the moment of a particular negative event, could there be friendship? The element of conversation develops friendship. And I think that at the present time, the current time with patients, 10 minutes, 12 minutes, 15 minutes, doesn't allow you to know those patients as well. So we have conflicting issues. Could you comment on both those issues of education and also time with the patient?
Well, I love your comment. I think it's something that both physicians and patients treasure, is that friendship, that, you know, when it happens. It's what I look for in my provider, certainly someone who knows me, someone who sees me. We have a great film at MedStar called Please See Me, and it's basically a dialogue between a doctor and a patient about seeing each other and understanding the stresses each other are under. So I think it's key. I marvel at the fact that we have been slow to incorporate some of these concepts into education. I know it's a world that I don't quite understand how that works or who's in charge of it, but I'm surprised that it hasn't gotten more root there. And I'm very proud of the work that MedStar has done to kind of, you know, do the summer camps to try to start it there, because those people are just enthused. Again, when you bring patients and families together in those camps, they connect with empathy and friendship right away.
Yeah, I'll just say, I think you articulated something hugely important. When you ask many, many physicians what they find most valuable about their work, what they would miss, what gives them meaning, it is about the human connections. Obviously, that's different with some patients than others. So at that one-on-one level, I think it's hugely important to clinicians as well. At the same time, from a population or system perspective for how we manage healthcare, I think we're kind of dumb, right? I mean, we've got this one-size-fits-all because we've got a billing code for it, and we just start, you know, shoveling people through. A local system here in Baltimore, is LifeBridge the right name? Yeah. So a friend was the CEO there for a few years, and he was telling me about this innovation group they worked with. Of course, they didn't realize that working with them meant they'd have to build the back end, but never mind. But, you know, use something far, far simpler, which was not humans directly engaging with people. I don't mean that the computer did it right, but they were using text messages to follow up with people after hospital discharge. And, you know, they did so much of the grunt work of setting up the systems that they'd almost forgotten that it might work. And they reduced readmissions dramatically because they had built a kind of customized algorithm. Jill, are you doing okay? Are you having problems with meds, your next appointment, whatever? And if the answer to all those is no, fine, we leave you alone, you're doing good. But anyone says yes, and there's another customized protocol. So I think that we could be smarter about that rather than making everything the visit. I have a couple of docs I would say friends with. And I hate that they work in a system that makes it almost impossible to see them. You can't call them on the phone. Now, I get it, you got to manage, have a real life and balance and all that, and when I get in there, I am so happy to see them. This all washes away. I develop amnesia till the next time, you know. I've got an issue and I don't really have time and they don't have an appointment for months, right? So I think we've got to get a lot smarter about how we use, that is the most valuable resource we got. Information and communication, which means we've got to be much more than 19th century about how we manage our time.
Judith?
Yeah, Judith Novak here. I'm obviously a great supporter of Candor, and one of the things that I'm, I think, uniquely positioned to talk about is patients and families not being listened to by doctors. So I'll tell you one story, and I'm going to tell it on a British doctor. My husband was British, and it was his gastroenterologist who was very famous, and I won't say who it was. My husband had ulcerative colitis, and he was put on mercaptopurine, and he developed this has a good outcome. Nothing bad in the long run happened. He developed a Kaposi's sarcoma, and this doctor wouldn't listen to me. And he wouldn't admit that either it was a Kaposi or that it could be caused by the immunosuppression of mercaptopurine. Well, I did make sure that the mercaptopurine was stopped, and in fact, the Kaposi's dissipated and went away. And in this case, I knew that this doctor, because this was an ongoing issue, didn't listen to me for 3 reasons. Number 1, I was a psychiatrist. Number 2, I was a woman. And number 3, I was an American and not British. So that's just one of probably a million stories that one could have. And how often do these kinds of relational interactions occur, and it occurs with people who, aren't medically knowledgeable enough to be able to fight it? So.
Well, yeah, judging from my large extended family who calls me all the time, I'd say it happens a lot.
Judith, one of the things I think we need to do is re-socialize just people, too, to think of this as our healthcare system. It belongs to us. It's supposed to work for us. That was just cooked out of us. We don't get that in school. We get defer to the experts. And we want their expertise, but we also want to be heard and listened to. I've been part of a team with 2 end-of-life journeys for my parents. And honestly, we just play good cop, bad cop. I go in and fire people, and my siblings say, well, he's a really nice guy, and help me clean up the mess afterwards, because someone has got to do that. When you have someone who's not listening to you, they're not the right person for you. And you can kind of find people in any system, I think, at least the ones I've known, that you have to search for them. And most of us are afraid to speak up. I learned that from an air traffic controller who was a cancer patient, and she had 2 family members that were both in recovery. And she didn't want them to be her team members because she was going to be worrying more about them falling off the wagon than anything else. So she went to her air traffic control tower in Minneapolis, and with a shift report, a shift schedule, and she got all of her coworkers to do 24/7 presence in the hospital with her to help her be the best patient she could be, because she said, I'm going to be drugged, I'm going to be scared, I'm going to be afraid. But I thought that was really creative, and I draw on that when I think about that. Thank you.
Okay. Jack, where's the microphone? We just, I figured we'd take one more question since we're at 8 o'clock, and yeah. There you go, sir. Finish with Jack.
You're giving me the last word. Thank you. Every night, I see the numbers on the television. They talk about medical errors as the 3rd leading cause of death in the United States. They quote the numbers of 251,000 people die every year in this country from medical errors. So if you have a loved one who has died, or a loved one who's been injured due to a medical error, call this law firm. And I think that's the problem. Marty, when you were walking on the dark side, but the hospitals need to get their in-house attorneys on board as much as their administration on board. Because and I like to make the reference, but you get more bees with honey than you do with vinegar. So when the doctors can approach the patient and say, hey, this was my fault, and then the hospital supports them, you get more bees with honey. They become advocates for you, maybe not all the times, but more often than not. And I think it's good for the insurance companies. The only people that really lose in this deal, for the most part, are the attorneys. So by getting advocates, I think the claims become less, and I think we would find, and it has been shown, that settlements are less than if it ends up in court. So thanks for the last word.
Oh, thanks. Let him hold it one more second. So people don't know, and my friends have heard me say this, Jack Gentry and Teresa are my heroes in many ways. Jack comes to our Telluride Patient Safety Summer Camps, and he's there with the students and residents. He's engaged. He shares his story, and he shares the importance of being open and honest and the difference it meant in his follow-up. And he finishes it with a comment about, what do you want the students to be, Jack, and what are they and what are you?
I want them to be my bumblebees. And as my bumblebees, they are to take all the information that we provide and Dave and the staff provide them in reference to patient safety and transparency and open communications as if it was pollen. And they're to take it back to their health system and spread that pollen amongst their colleagues or their medical students. And they are my bumblebees.
And then he goes home and creates a whole set of T-shirts with bumblebees and pollen on them to share with the students and stuff to move forward. So we are at the end of our time. I've got to just thank our panelists so much. Carolyn, Marty, what a great night. Thank you so much. And we've got similar gifts for you that hopefully you'll hang in your offices or wherever proudly. And I think we've got a reception afterwards with some dessert and coffee and everything, so we could continue to mingle and discuss. But thank you all for coming tonight. Very powerful.